Welcome to the High Impact Medicine podcast. High Impact Medicine is a community of doctors and medical students who are thinking about ways to lead impactful and meaningful careers. Our podcast will feature interviews and discussions, which we hope will leave you both inspired and informed. My name is Tanya Kismich, and today I'm speaking to Dr. Adrian Boyle. Dr. Boyle is an emergency medicine consultant at Addenbrooke Hospital and the Vice President of the Royal College of Emergency Medicine. He speaks about his professional journey, and I was particularly curious about his experience scaling the Cardiff Model, which is a multi-agency approach to violence prevention. There is a lot of wisdom in this episode that made me think about the value of collaboration, influence, and storytelling. I hope you enjoy. So today I'm joined by Dr. Adrian Boyle, and he will introduce a little bit about himself.
Okay, so I'm a consultant in emergency medicine at Addenbrooke Hospital in Cambridge. I qualified in 1994. I went to Southampton University. I did a variety of jobs, what used to be called house jobs, which would be the F1. Then worked abroad for a year. Wasn't really sure what I wanted to do. The specialty of emergency medicine didn't really exist. I dabbled with being a surgeon and then thought about being a cardiologist because I like the acute, exciting stuff, but eventually settled on emergency medicine. I became a registrar in emergency medicine in about 1998, and then took a year out to go off and do a master's, which I'd really recommend, and then a doctorate afterwards. I became a consultant in 2005.
Mm-hmm. And what experiences have you had outside of your clinical practice?
So working abroad, I spent just under a year working in South Africa, was incredibly revealing. It really showed me that, yes, clinical care is really important and sometimes it makes a lot of difference, but also there's much bigger factors at play which affect health. And I think one of the things I've got from that is a desire to integrate public health principles into routine clinical practice. I think doctors are trained very much to see everything through the lens of their patient or their specialty, but sometimes having a much bigger appreciation of all the problems and the determinants of what's harming that patient is actually really important, and actually leads you down to do things in slightly different ways.
Mm-hmm. And could you give us an example of this type of thinking?
Yeah, so I'm an emergency medicine doctor. I see lots and lots of victims of violence, intentional assaults, and I got really my research interest. My master's was all about trying to help people affected by domestic violence. So I started off with some basic public health accounting, how many people are going to an emergency department are actually victims of domestic violence, and it's about the same prevalence as the normal population, which is unsurprising. And actually, individual instances are quite rare. They're important, but they're quite rare. I then got interested in how you could use emergency medicine data, and I saw this amazing presentation. I went to a conference, and there are sometimes in your career you have these light bulb moments. And it was a professor of facial surgery, a guy called Jonathan Shepherd. He's now retired, but he's a professor of facial surgery in Max Fax, and he put up all these pictures of people with horrendous cuts that had largely been caused by people breaking glasses in pubs and smashing them into people's faces. And I thought, oh, here we go again. It's going to be one of those talks about I do this sort of stitches and I do this sort of aftercare and don't the results look great? And I thought this is going to be quite boring. And he said, I got really bored of seeing these people with glassing injuries to their face. So I lobbied the government to change the glass in beer glasses. And it's absolutely true. It took him about 5 years to do, but that sort of smart public health type intervention just made the problem go away. And you can see this, the sort of glass that's in beer glasses in pubs, it's the same sort of stuff that's in windscreens. So if you actually manage to break it, and they're pretty hard to break, it crumbles away into pebbles rather than sharp, jagged edges. And that problem just went away. And that was, it was a fairly inspirational moment for me, seeing that you could actually design out a lot of the problems. And you see these sort of these fixes around. So next time you make a cup of tea, and you boil a kettle, you'll notice that the flex is really short. The flex for a kettle should always be really short, and that stops children pulling kettles over onto themselves. They've designed out that problem. Do that, and you reduce the amount of kids who get burned.
Mm-hmm. That is a really inspiring story. And how did you then translate these principles?
Well, I started following this guy, and I would meet him in various research meetings, and we talked about things. And he developed a system called the Cardiff Model, where he would ask his receptionist in his emergency department to tell people where they had been assaulted. And it's a form of, in public health terms, it's a form of injury surveillance. It's active surveillance. You go out and find out where the problems are. And the bits of information you got was what weapon was used, where did this happen, and when did it happen? And then each month, that information gets fed back to the local police, the licensing authorities, the city council. And when they started doing that, they were able to be much smarter at reducing the amount of violent crime victims who needed hospital treatment. And by doing that, over time, they're able to take 30% of the cases and prevent 30% of cases requiring emergency department treatment. Not only that, the police had less violent crime to do. So it was a really simple, effective thing. Now, that worked well in a university system, probably a bit of research funding behind it, quite a lot of effort. But what we were able to demonstrate locally in my hospital and in a number of other hospitals is where you start doing this, you stop 30% of violent crime victims needing emergency care. And that's got to be great. And then certainly in my own experience in my own hospital is we stop 200 to 300 victims a year requiring hospital treatment. And we feel really good about that.
Mm-hmm. And the intervention itself, I read about the Cardiff model that for every $1 spent, you save $20 in criminal justice costs and $15 in health system costs.
Oh, yeah. I mean, these interventions are incredibly cost effective. But it's more like £1 spent saves £87 worth. I mean, it's incredibly cost effective. Violent crime is very, very expensive. And that's even before you account for sort of the hidden economic costs. The fact that somebody doesn't go to work the next day because they feel awful, or they can't go to work because they need to have stitches removed. The fact that they might trigger a mental health crisis in somebody who's a bit vulnerable. All of these things, it's very cost effective. It's not very glamorous. And sometimes I got slightly ridiculous challenge from people who didn't want to do this, where they're saying, well, it's part of emergency medicine. We look after people who have been in fights. And nobody actually said it to me, but you got the feeling that they liked seeing people who'd been assaulted. And I think you just need sometimes to ground yourself in the humanity of what you're trying to do. Yes, it's great to try and do nice suturing, nice technical stuff, and perhaps do some life-saving interventions, but isn't it even better to try and prevent that happening in the first place?
Yeah, I completely agree. What were then the challenges of implementing this?
Yeah, so there's a whole bunch of challenges trying to do an intervention like this. First of all, you've got to make sure that the receptionists were prepared to collect the data, and we got a bit of money to make sure that our IT system could actually allow people to do this. People would often hide behind NHS IT. I mean, NHS IT is terrible, and it's really inflexible, and it's really difficult. But also people would use, it needs something in a computer. You're using NHS IT, it can't be done. So there was a lot about actual building up relationships with people, talking to our receptionists and telling them why that this was important. We also a lot of this was actually about relationships with people outside the hospital. So we invited the police, and we got a senior police officer to come and talk to our receptionist, and he turned up in full uniform, which they all quite liked. But actually, it gave them a sense of purpose. So people will do stuff if they feel they can see the point and they get a sense of purpose. And I had one receptionist who said, this is absolutely not my job. I'm not doing this. I'm not going to, because sometimes it's a bit icky. And being a receptionist in an emergency department is sometimes not a pleasant job. You have anxious, stressed people who want to be seen immediately. Some of them are drunk. Some of them are a bit strange to start with. If you hang around emergency departments long enough, you will see people who are a bit strange. And they sometimes just want to process people as quickly as they can. So she was very resistant until her son got assaulted in a nightclub. And then on the Monday morning, the whole thing was, he wasn't badly injured, but she was clearly upset and shaken by it. And she came to me on the Monday morning and said, how can I help? What can I do to stop this happening? Now, I felt bad for her and her son, because it's a nasty thing to go through. But also, it was a good opportunity for me to try and get this done. And she actually became our strongest champion. And you could see her nudging people to make sure that they were done. They would collect this data. Each month, when I collect the data, I show it to the receptionists. And I show that you are showing where these places are coming. And if you ever want now to know where not to go out, talk to our emergency department receptionists. They will know what's hot, what's not, around where's good to go, where's not to go. So the first thing was getting the data. The second thing is making sure that the data goes to the right place. When I started, I just sent it to an anonymous email address at the county council, and it wasn't being used. It was just sitting in somebody's inbox. You might flick through and go, ooh, this looks a bit interesting, but not doing anything with it. So you've got to identify who can actually take action on something. When I started sharing it directly with the police officer who had responsibility for licensing, suddenly it became much more effective. And their feedback, which I then shared with the receptionist, created a virtuous cycle. High quality data led to action, led to feedback, led to even better data. And now our receptionist, it's very much business as usual.
I found it an interesting point in the story that people are persuaded more just by personal experiences and their own interest to do things. How effective is reason, or just showing people the numbers or the stats? How effective is that at persuading them?
Yeah, so I spent a lot of time thinking about how you gain influence. And you've got to target your messages really carefully. Now, as doctors, I think we get used to looking at graphs and looking at detailed evidence-based explanations. With a lot of people, that simply doesn't work. And actually, you need what the army would call both a hearts and minds approach. And I think if I'm guilty of anything, I think I do too much on the minds and not the hearts. So having good stories, and I think I don't think we use patient stories enough for influence. I think trying to get stories which explain what's happening, and you see some charities that are absolutely brilliant at this in terms of leveraging public opinion, getting people to do things they might not want to do in a way that is much more human. We all grow up listening to stories. We watch stories for fun. You turn on the TV in the evening and watch a drama. It's a story. Nobody gets up and reads, apart from University of Cambridge students, a scientific paper for fun.
Yeah. Okay, so it worked really well in the Cambridge vicinity. And then what did you do?
So we got noticed by doing this well. I'd go to conferences and I'd talk about it. And I got invited to go to the Home Office and it attracted the attention of a minister in the Conservative Lib Dem coalition government all these years ago. We've been doing it for 5 years. We've seen this massive helpful reduction in the number of assault cases. And we got invited to go and suggest how this might be rolled out nationally. And that was really interesting. So I'd go to the Home Office and we'd sit in as part of a working group with people from the Home Office and the Department of Health, trying to work out how to implement this nationally. It's a real challenge because you could sort of give somebody a template and an IT fix and tell people that it was a good thing to do. But the work that I'd done about relationships and encouraging people to do it, that takes time. And in England, there's probably about 180 emergency departments. No one's got time to go around to all of them to encourage to do them and do that shoe leather work. So we spend a lot of time thinking about how we might influence people. We set up audit standards. Some places will do it and some places wouldn't. We tried to various ways of paying hospitals to set up the process. It was quite difficult. At one stage, we reckoned that we had about 60% of hospitals doing it. We had to manage people's expectations of this quite carefully. People would say, oh, you're collecting this data. Can you tell me about child abuse? Can you tell me about domestic violence? Can you tell me about immigrant violence? Can you tell me about trafficking? And you go, no. Those are complicated, difficult things to identify. You've got to remember this is information which is gleaned by a receptionist at the queue. So we had to be quite boundaried about what we could and couldn't do. And there was quite a lot of work making sure that everybody understood what we were trying to do. I suspect now, unfortunately, it may have drifted a bit. I've been pulled over to do other things. I've got one of the great problems with the NHS is if you show you're good at something, you get asked to go and do something hard, and if you do well at that, they keep pushing into till you find your failure point. So I'm not quite sure I've achieved my failure point, though my colleagues might agree.
So what are you up to right now then?
So I am now president of the Royal College. So my job is to represent all emergency medicine clinicians to government and make sure that the college does its job properly around doing exams, training doctors. So it's a lot of responsibility, and unfortunately, it takes me away from the bits of my job that I like, seeing patients and teaching. But again, also it's really interesting.
Mm-hmm. I'm tempted to ask, what have you learned about gaining influence over people, and what have been your mistakes and successes?
I think that's a really good question. So I think to be effective in anything, you need how you gain influence is you need to think about this really quite carefully. And it's not the moment you find yourself saying, you're supposed to do this, or why won't you do this? You've lost your chance of actually, you've got to recognize you're failing to get influence. So I spend a lot of time, and I debate with my members, with my exec team at the college, the best way about getting influence, because it's complicated. And I think a lot of it depends on time. A lot of it depends on actually having that time to build up relationships. And I think it's become even more important in this new virtual world where all meetings are online, that if you want to gain influence, you need to have that time face-to-face, meeting people, making sure you're aligned. You don't have to like people, and they don't have to like you. In fact, I think it's a problem if people want to be liked. I think that's a problem. You need to make sure that you're trying to get your point across, but also to appear collaborative. It's very easy for me as president of Royal College to go, everything is terrible all the time, and you must do this. And that's probably ineffective, because most people's innate response will be to fold their arms and stick their fingers in the air, in their ears, and hope that I go away. And actually, what's better is to go, we've got this problem. It's a shared problem. How can we help? How can we work together to try and make this better? So you've got to be, and I'm a large sport-driven man. I played a lot of rugby. Did lots of fairly adversarial sports. My temptation to be a little bit confrontational needs to be absolutely swallowed. And particularly with being in the Royal College, I have influence, but I have absolutely no power. So thinking about how people can be influential, and I'm sure there's a lot of science behind it, which I don't pretend to understand, but certainly being open and collaborative and approachable is, I think, key to making these things work.
That's very interesting to hear. Okay, so on the personal side, that's the advice for careers in public health influence. And what other advice would you give to medics who want to do something similar to what you've done?
So I think one of the formative moments for me was actually going away and doing a master's in epidemiology and biostatistics. And it sounds deathly dull, and I don't particularly like maths, but the epidemiology and being taught how to think through difficult problems was really useful. And taking a slightly bigger global perspective rather than just becoming really, really amazing at clinical care, I think was really valuable. And I know people feel training is expensive and it's probably too long, but it was really helpful to me. That little bit of extra time just to be taught how to think through things in a slightly different way. I think one of the criticisms I have of modern medical training is we take very, very bright people and drill them. And I can understand why that sometimes that's necessary, but I think we're also wasting their talent sometimes.
Yeah. And do you think people can do this research experience at any point in their career, or is it better to do it earlier on?
So I never intended to go down a research route. The only reason I took time out was that I got onto a fairly short training program, and I could see that I was going to be a consultant fairly quickly. And I just thought, this is a bit too soon. I need to find some sort of delaying tactic. I had married somebody who wasn't able to travel, so I wasn't able to go off and do further time abroad or anything interesting like that. So I needed some sort of delaying tactic. But then it was absolutely transformative for me. I don't think there's any particular right time. I think it really helps organisations like Health Education England and NHS to do these workforce planning that say, oh, if we put these people here in this amount of time, then this will translate to this number of consultants by this time. And I can see why they might want to do that. But I think actually for your own career, you've got to do what feels right at the time. And it's okay to take a bit of a walk in the woods. I think the idea that you shorten training just to get people through some sort of sausage factory doesn't feel right. I think people are better if they take a bit more time sometimes to go and explore their interests.
Mm-hmm. And as we're rounding up, is there any sort of advice that you would give to medics?
I think it's very tough to be a junior doctor at the moment for a variety of reasons. I would try and make sure that the big thing that I'm trying to do is make sure you've got a peer group and around you. It can be medicine is hard in ways that you don't necessarily expect. And, you get trained to deal with the breaking bad news, the unexpected sudden bereavement, the second victim after something goes wrong. What people don't really train you is that sometimes the working conditions are just feel brutal and nasty. And I think you need, one of the observations I've had over my career is that I think people coming through now don't have that peer support network that I used to have, and I really used to rely on. Now, I was a junior doctor, and I did massively long hours, but also, and I would never say that I had it easy, but what I did have was a peer support mechanism. And I think modern working practices, the constant industrialization of hospital care can make for a quite unpleasant working environment. And the best antidote to that is having peer support around you. And I feel very worried about junior doctors who are teleported to different parts of the country where they know no one and they're expected to turn up and be a functional professional in a strange hospital, strange career, first day in the workplace. So my big advice would build up your peer support network and take it with you as much as you can.
Okay, that's a good thing to keep in mind, and you're the second person that's given me this advice to invest as much as I can into the peer support group, even during medical school.
Yeah, medicine's tough, and it's tough in way. So we used to have a psychologist working in our department, and she turned up, didn't know anything about emergency medicine, and on the first day she said, "How do you cope with cardiac arrests and sudden deaths?" And we went, "Well, that's fine." I said, "So what bothers you?" And she said, "Well, you talk to the staff, see what you think." And she went, "Oh, I get it." A week later, she said, "You're worried about nowhere to change, nowhere to park. You're worried about too much work, the risk of making a mistake because there's too many people that you're looking after, adversarial relationships between different staff members. it was all about working environment than the actual work itself.
Well, on that cheery note, I want to thank you for your time and for the conversation.
It's been a blast. Thank you.